Hi, good evening, all our esteemed members of Maharashtra Ophthalmological Society and all our members who are also joining us from across the country, from AIS as well. We know that MOS is possibly the largest state society of India right now and does a lot of scientific activities. This month has been dedicated to cornea, where we have already conducted two cornea postgraduate programs. And this is a very special webinar where for comprehensive ophthalmologists, this has been curated to showcase to them, to give them the pulse on how they can manage on their own very small corneal procedures and when to refer to a so this has been put together with the help of our very dynamic and very scientific member, Dr. Swapnil Bhalekar, who has coordinated all this webinar. He has put up the show together, and he's going to be also the moderator for the session today. Before we start the webinar now, I would like to invite our Honorable President, Dr. Santosh Balsar, to please give his small welcome address, and then we will proceed. Over to you, sir.
Yeah, thank you, Vardhaman. Uh, so, very good evening to one and all. At the outset, I thank all the panelists, moderator, all experts, faculties, my MOS teammates, and respected teachers, and all the esteemed MOS members. I welcome you all to this very unique webinar wherein we are mainly focusing on the corneal small procedures. In day-to-day practice, we usually uh, do all these procedures. But what happens many times, small do and don'ts we don't know. So we can refine our procedures and we can update our knowledge and what small nuances and the intricacies in these procedures that we can update our knowledge in this regard. And experts are there to guide us today. So this is very unique and very enlightening webinar, which was curated by our own dynamic scientific committee chairman, Dr. Vardhaman, Aditi, and Dr. Bhalekar, and everybody who has participated in this webinar. I thanks once again to all those stalwarts, and definitely we will have a good knowledge and enlightening session today. So thank you very much, and over to Dr. Vardhaman.
Thank you very much, sir. So I think without further ado, now I would like to invite the moderator and the chief coordinator for today's webinar, Dr. Swapnil Bhandekar. Dr. Swapnil is a very dynamic cornea, refractive and especially ocular surface surgeon trained at LB Prasad and doing remarkable work in the Taluka place of Shirur. And he has been really doing absolutely outstanding work in such a small place and has been treating patients with very complex corneal disorders who are referred to him from everywhere in the state and beyond. So I would like to thank again Swapnil to have coordinated this session today. And I would like to now hand over the proceedings of the session to Swapnil, please. Over to you, Swapnil. Thank you.
Thank you, Vardhaman, Dr. Agrawal, Aditi, everyone for the nice session and giving us the opportunity to be here. Without wasting time, I would request Dr. Rajat Jain, who is a cornea surgeon, passed out from LBPI. He is practicing in Delhi. So he has also published a lot of things about desmatopexy. So I requested him specially that, if he can present about desmatopexy, the right technique to our general ophthalmologist. So I'd request Rajat, can you please share your screen and go ahead with your presentation?
Yes. Yes. Good evening, everybody. So let's share screen button. Is my screen visible now?
Yes, right.
Okay. So may I start, Swapnil?
Yes, please go ahead.
Yeah, thank you. So thanks, Swapnil, for inviting me to the amazing webinar. So probably he has requested me to speak on this because Dr. Somshila is here. She was my mentor in LVP, and this was my first publication ever in my journey, and this was published in ophthalmology. So we'll discuss in brief the technique. So this is a patient. And fortunately, this patient I received only 2 days back. That is on 18th, I operated this patient. She was a 78-year-old female, surgery, cataract surgery, uneventful cataract surgery by a very accomplished surgeon in Delhi, done about a month or 5 weeks back. And she was referred to me as TAS for DSEC. The vision, as you would expect, was around 2 meters unaided. So, a simple test. First point of learning would be any patient of post cataract surgery edema, please do a intrasegmentosity, readily available these days in all major practices. What you see very common, very easily is a complete DMD. See the desmoid is detached from one area to the other. It's around a 6 millimeter scan, and you can see it is almost completely detached. So this was a missed DMD, and hence I would recommend we always do a intrasegmentosity whenever there is an edema which we are seeing post cataract surgery. Now directly diving to the video. A few tips first. Number one, this is a temporal view. I'm a temporal surgeon, so this is temporal and this is the superior part. What you notice is that the desmoid, although it is a complete edema, but it is more focused in the inferior area, in the like central and the inferior area. This area appears to be relatively spared. I'll tell you why this is important in just a little bit. So if we move this video forward, we have to make a 20 gauge stab incision, a side port incision. Again, as I told you earlier, the edema is more in the inferior part. So we always choose an area which is literally clear so that you are sure that you are entering the antechamber. Also, another point what you could do if there's a total edema is while entering the antechamber, you touch the iris with the side port so that you are sure that you're not in the plane between the iris, between the desmoid and the cornea. Second is there are multiple hydrocannulas which are available in the market. I would always prefer using a horizontally flat cannula for this desmoidopexy purposes. Now, what is ideal is a slow, sustained release of a single large bubble. Very good. But what happens is that if there's a side port incision, this air always tends to come back out. So what I would always recommend, even I do right now also, till now also, is make a side port, first put a suture in the side port. Once you put a suture, it is very difficult for the air which you are putting inside to come out. So now you see when once I clear this blood off and I put the air bubble inside, this bubble there will be a decreased tendency of the bubble to come out. So second point of remembering would be to put a bubble. Then do a lot of massage. What you have to do is try to attain a single large bubble because the convexity of the bubble is what is supposed to attach the desmoids. You might also have to remove the air bubble and insert it again. Not ideal though, but again you have to aim for a single large bubble that will serve the best purpose. Now what you notice here is a very striking feature that there are two bubbles formed. The second bubble which I am trying to coalesce, it is not coalescing, it is probably anterior to the desmoids in the Duas layer. So you have to get this out so that the DM is nicely opposed. Oblique 26 gauge is used, very oblique, very slow, and you can get it out. And now we have a single large bubble which is opposing the DM to the posterior surface of the cornea. See the hardness. You have to aim for a stony hard eye. See this eye is not getting compressed. This DMD, remember, is more than 4 to 5 weeks old. So aim for a stony hard eye and then do multiple massages in all directions. In all directions in this patient because it was a complete DMD. If it is a partial DMD, you would always do it from the center to the periphery so that the air is removed from the interface. Use a bud, use a back surface of the curved forceps, use a cannula, whatever you use, do a lot of massage. So you have to leave the eyeball stony hard for about 8 to 10 minutes. That's what I do. Then what you would notice on table, that will be very striking. See, this is the back surface of the curved forceps. Very nice to do a massage. Epithelium comes off, not a problem, it will come back. Now see on table, you will see these droplets on the corneal surface. This is the water which is coming out from the stroma anteriorly. This is a on-table sign of clearing of the corneal edema and the DM that is opposed. In high focus, you can see these droplets coming out from the stroma. Once you clear this off, you can appreciate that the cornea has become clearer as compared to what it was before surgery. Again, bear in mind, it's a 4 to 5 weeks old, complete desmoid, a 74-year-old female. So what you do next is just remove the little bit of air and leave a moving air bubble. Tell the patient to lie supine for 2 days and apply a bandage continence. And hope and pray that the DM attaches. So this is the end of the video. Now I'll show you the result. This patient I operated on Friday, that is day before yesterday. This is post-op day 1 picture. You see the cornea has cleared like very much as compared to what it was previously. You can still see the DM which is in wrinkles because it was a very old decimal detachment. 60% air bubble is still left. Vision is as of now not there because of the large air bubble, but the cornea is clearer. If you see the OCT, see the DM is thickened, which you would expect in a 74-year-old, a 78 or a 74-year-old female, but it is attached under the air bubble. So what I tell the patients is you have to wait for the bubble to go because right now it is DM is attached because there's a tamponading force. Once this tamponade goes away, then actual thing will come out whether it is attached or not. So this is the picture of Saturday, and this is today morning. Now you see that the air is almost 30 to 20 to 30% left. Cornea is clearer, vision is improving. Now I would expect this cornea to stay clearer because now the tamponading effect is almost minimal, and I would not expect the DM now to go back. Although once this air goes on completely, then we'll be really sure. But now also I would be pretty much sure that the cornea will clear on itself. This is the DMD. This is the antisymetocity picture as on today morning. So you appreciate this preoperative one that is on 18th. The middle image is of Saturday, and this is today. So this is what I am supposed to say in this. And if there are any questions, I'll be very happy to take them.
Rajat, would you be able to tell to our audience that is it nice idea to do a PI when you are leaving behind a large air bubble?
Yes. So leaving a PI would make your life very easy and very safe at night. So what I do is we as cornea surgeons are well versed with doing DSEC. So probably I don't do PI in all my DSEC cases. But yes, for beginners, definitely if you do an inferior PI with a retractor and then leave a air bubble, your life is very easy and your patients, the chances of them having a pupillary block would be minimal. Yes.
And any choice of air versus C3F8 gas?
Yeah, so this was the idea with which we started the study. So we have a published study in Ophthalmology Journal in which we compared the retrospective outcomes of air versus C3F8 in post-cataract surgery desmoid Dr. Somshila was my mentor in that article. She's also online. So what we found out was that the efficacy rates were similar whether you use air or C3F8, but the pupillary block rates were higher when we use C3F8. So because the efficacy rates were similar, till that practice, I haven't used any gas other than air for any attachment of DMs in my practice. It's not required, I think. If it has to attach, it will attach in 8 to 10 minutes. It's not required to be put for further long.
Thank you so much, Dr. Rajat. So we'll move ahead.
Sir, yeah. I have two questions.
Yes,
you are making the eyeball very stony hard. So
yes,
will it make any disc perfusion problem?
Sir, for the 8 to 10 minutes, if you make it stony hard, it usually doesn't, because in DSECs also, what is recommended by the price group is that you make the eye hard for about 8 to 10 minutes. So it usually doesn't. We have been doing it for so many years now. It doesn't. In the initial part, you think it might happen, but it doesn't happen like that. 8 to 10 minutes of stony hard eyeball is fine. Nothing happens.
Second question is why not you use the needle to pierce the antechamber and then put the air instead of doing the side port? Because
there is no area through which the aqueous will come out. You have to replace the aqueous with the air. Only then that force will, that buoyant force, that convexity of the bubble will attach the DM onto the posterior corneal surface. So that aqueous has to come out. Only then the able will take place.
Then 2 needle techniques can you use?
2 needles for what, sir?
1 needle for just drainage of that aqueous and 1 needle for putting the air inside the antechamber.
I have never used it. I don't know if it will help or not, but there is a very simple technique. So I don't think this is a very simple and a reproducible technique. So you just make a simple side port, however small it is, and you suture it. The air will not come out. Then it is just a matter of you releasing the air slowly and in a sustained manner. Because if you do it like in Jhatkes, then you'll have multiple fish egg bubbles. That is not what is ideal. You have to keep a slow, sustained increase of release of the bubble. You get a very good round bubble. Even if there are 2, if you just tap on them, they coalesce. So that is not a problem. The only issue is it should not come out. So if you put a suture, it doesn't come out.
And what is your experience? How many days you require for attachment of this descent membrane? So that we can decide about C3F8 then.
Yeah, sir, I'll answer your question in 2 parts. Number 1, at what point in time you will know that the DM is attached? The complete surety will be only once the complete air is gone. But if it has to attach, it will attach on table, and you can come to know on day 1 if the cornea is clearing or not. But if the cornea is not clearing, you know it is not attached. If it is clearing, you still wait for the air to go. Number 1. Number two, your second part that you have, whether should you use C3F8 in the second sitting? So I again reiterate my statement that using a C3F8 only gives the surgeon a false assurance that it will stay in the anterior chamber for a longer time. If the DM has to attach, it will attach in the first 8 to 10 minutes. So air versus C3F8 is required when you need to, for it to, attachment for a longer time. But the longer time is not required. It is just that inmates are there, you have to give proper massage, it attaches.
Okay, thank you very much.
Thank you.
Sir, I have a question.
Yes, sir.
Yeah. So, Dr. Rajat, is there any need of venting incision when we are doing this desmetopexy?
So we tend to do some venting incisions sometimes in D-sex, but this DM is so fragile that if you do venting incisions and that DM, if that something touches the DM, it just rips off, then you can forget about it attaching. When you're doing a D-sec, you are touching the stroma, so that is less fragile. In DMDs, we don't do D-sex because there's more to lose there.
Any other question? Great. Thank you, Rajat. That was nice presentation. May I invite Dr. Asmita Patne to present her video on corneal tear repair?
Yes. Just one minute interference. 1 minute. Rahul, Dr. Kunjal Sejpal needs some assistance for the Zoom platform. Will you please call her? Maybe I can send you her number on your phone number. Okay? Okay. Please continue.
Hello and good evening, everyone. Is the screen visible? Am I audible?
Yes, absolutely.
Right. Yes, so corneal tear repair, it's actually not a very cornea specific topic because this is something we've been doing as PGs, and a lot of general ophthalmologists are already doing this. So these basic principles we all know. I'm only going to add some few tips that probably I learned when I learned cornea, when you do keratoplasty, some tips related to suturing. So I'm skipping the pre-op evaluation part and let's jump straight to the OT. So when it comes to anesthesia, I generally avoid a peribulbar block because that you can't give a massage. It might increase the positive pressure, and then especially in cases where the iris prolapse, it will keep popping out. GA is preferable; it's the best choice. But if that's not available or possible, then it's a very good idea to add a facial block or a lid block. If the patient is very cooperative, a small tear can be done on the topical, or a subtenance anesthesia works really well. And if you haven't tried it, you should try subtenance with a facial or a lid block. Always debride the epithelium over the iris and the surrounding cornea for 3 reasons. One is it has been exposed to the microorganisms. Secondly, when you reposit the iris back inside, you don't want that epithelium to go inside to avoid the inclusion cysts and complications like epithelial downgrowth. Third, while forming the anterior chamber, it's a very shallow and a flat AC, so you have to be very gentle. Go a little flat with your side port and see that the tip is visible throughout, so that which means it is not gone under the iris and you're not puncturing the iris and the lens. Like in this case, there is a hypopyon. So if you have any material that's infective, hypopyon or infiltrate, please scrape it and collect that material and send for a microbiological workup. That will really help later. Now, forming the anterior chamber can be done with air or with visco. So initially I used to do with air, but then I've learned my lesson that it's not very, it becomes more cumbersome because it keeps collapsing every time you go into the AC and come out. So visco is a good choice, especially if there is an iris prolapse. If there's no iris prolapse, if it's a small tear, you can do with air. While repositing the iris back into the anterior chamber, if you find some initial resistance, please stop. Don't try hard, you'll cause iridodialysis. Come out, slightly loosen the iris from the wound margins, and then retry repositing it back. It will be easier. At this point, it is a good idea to add pilocarpine because when the pupil constricts, it will keep the iris pulled in. In some cases, after trying all this, if still difficult, you can gently put the iris in, but you don't want to perforate or go through and through. Now comes the most important part of this surgery is how do you suture and where do you put your first suture. So this take a minute and plan the suturing before directly jumping in. So after your AC is formed, your iris has gone in, now you can see the wound configuration. So if any tear is involving the limbus, we know that the first suture has to be placed at the limbus and let it be a nice long suture. If it's a linear tear like this, if there is no gaping in the wound, you can put your first suture in the center and then the equidistant ones going peripherally. But if there is a gaping wound like this, it's better to put the sutures at the edges, in the ends, and reduce the gaping, and then put the central suture and then the in-between ones. Now the real challenge is when you have tears like this, which is dry radiate, that time bring out your artist from within and try what all you can. But it's good to know how to put a purse string suture. I'm not showing it here because of the short time, but you should know how to put a purse string suture for those apices. Now we all know that we have to put a suture at a depth of 80 to 90%, but how do we know that we are at the right depth? So so this is how we should not suture. So first is you don't want to hold the edges with the forceps, try not to. And if you see the needle is going very slant, it's almost parallel to the surface and it comes out slant. And when you pull out the suture straight, there is gaping of the wound. So this is not how it should be done. So what we want here is a perpendicular entry. So if you're not able to see the tip of the needle, your wrist is going to be pronated when you start suturing. And you literally have to supinate your wrist as your needle comes out. So if this maneuver you find difficult, then another way of doing it is once your needle goes, it comes out, you can little by little pull out the needle so that the curve is followed and you don't pull it out and the tissue is not distorted. This is an important look for a V sign to know if you're at the right depth. So yes, here. So when you are passing it through the right depth, 80 to 90%, you see this dent that happens in the posterior stroma. You see this V sign, which means you're at the right depth. If you're too superficial, you will not see this sign. And if you are through and through, you are definitely not going to see this sign. So always look for this V sign. Now, once you got your first suture in, the other sutures are followed. First complete the corneal part, and if the sclera is involved, do a good peritomy, explore the entire part, and then do the scleral bites. And then finally finishing your artistic surgery, make sure that it's all it's watertight, bury the knots away from the center, sweep the cannula under the repair so you know that there's nothing stuck there. If any loose suture, it is bound to happen that during subsequent sutures, your initial sutures become loose. Redo it. And if there is some resistance, like here, you see there is a resistance for the cannula at this point. And also this air bubble is guiding you. The air bubble is stopping here. It's not, the complete AC is not formed, which means there is something down here. Either you remove the suture and redo it, or you can use a micro scissor and cut if there is some iris, cut towards the corneal side. And if you suspect there is vitreous, it's a good idea to use a vitrectomy cutter and clean that part. And a little cheating is allowed. This is a cheating because if you try everything and still at the end you see it's not watertight, there are some leaks and ooze. Instead of leaving it like that, you can apply a thin film of cyanoacrylate glue over it, or put an amniotic membrane or a BCL. Honestly, I'm never satisfied with my corneal tears. I always feel there is something better I could have done. This could have been done in a better way. So thank you for your patient listening. And I hope the 5 minutes are worth listening to.
Thank you. Asmita, any questions?
I have one question. Can I ask?
Yes, please, sir.
If visual axis is involved in corneal tear, or your suture is bound to hamper your visual axis, how you will go about?
if we are going to pass the suture anywhere near the visual axis, it's advisable to take a longer one. So you don't want to take the bite through the visual axis. Take the longer bite so that the ends of the suture are away. Though the track may pass through the center, but that leaves relatively lesser scar than the ends of the sutures.
I had a quick question, Swapnil, if I can ask.
Yes, ma'am.
First of all, Asmita, excellent presentation, and really, really, you hit everything on the nail and got all the points so right. So I just thought that you didn't touch upon it, though it was not part of your topic, I guess. But what do you do for complex cases where you also have cataract, traumatic cataract, along with the corneal tear? So what do you do for those cases? Any tips?
Ma'am, there I would like to add, it depends on whether the anterior capsule is ruptured, whether it is intumescent. If it's not ruptured, then I would not prefer doing any cataract surgery at that point. So the idea is to create a watertight closure and clean whatever is there into the anterior chamber. So if there is vitreous prolapse, then do the sometimes you have iridodylisis and vitreous prolapse from that side, but the lens is not really disturbed, then I may not touch the lens. But if the capsule is breached, then depending on how bad it is, if your view is clear, you can definitely proceed and may not put an IOL because you will not get your IOL calculations right, but you can do the cataract part and leave the patient AFK and plan a secondary IOL. But if you have a good view. If not, then finish your corneal tear, clear the AC of whatever possible, wait for a few days, and then you can add steroids to control the inflammation from the cataract, and then redo the case.
Great, thank you.
Thank you, ma'am.
Any other question? Thank you so much, Asmita. It was excellent presentation. Next presenter is Dr. Prajakta Dandekar, who is a consultant cornea surgeon in SSCI Mumbai. She would be presenting on easy way to do amniotic membrane grafting in multiple situations. Yeah, please go ahead, Dr. Prajakta.
Can't hear you, Prajakta, if you're speaking. You're muted. You're muted.
Yeah, am I audible?
Yes. Yes.
Hello. I'll be presenting on amniotic membrane grafting. And are my slides moving?
Not yet.
Okay.
Yeah. Can you see my slide now?
Yes.
Yes.
Yeah. So coming to the historical perspective, amniotic membrane was first time used for as a part of human surgery for skin transplantation in 1910 by Dr. Davis. And later on, we started using it for ocular surgeries for ocular surface burns in 1946 when it was first introduced by D. Roth. But actually, we started using it as a replacement for conjunctiva only in 1992. Coming to the layers of the amniotic membrane, we have the basement membrane at the top, which is a part of the epithelium, but not the true epithelium, but a basement membrane at the top. Then there are the other layers, that is the spongy layer, that is the compact fibroblast and the spongy layer. Then other parts are the chorion, which we normally separate when we are using it as a part of our ocular surgeries. Coming to the properties, it is anti-inflammatory, antimicrobial, anti-scarring, and anti-adhesive properties are there. And anti-angiogenesis property is also there because it lacks the HLA A, B, and C kind of antigens, and also that is why it is low antigenic and there are no chances of rejection. Also because it is anti-scarring because it decreases the level of our transforming growth factors beta, so there is less of fibrosis. So it promotes epithelialization either when it is used as a when the epithelium is at the top or the epithelium is at the bottom. But generally when we use it when the epithelium is at the top and the stromal surface is at the lower side. There are different types of amniotic membranes in the market. The fresh ones is the cryopreserved membranes, which we often use. That is a freshly derived from the hospitals, which they derive it after a cesarean section. And the ladies in which this amniotic membrane or the viral markers are being done at 1 month and 6 months. And the lyophilized membranes are nothing but these are given radiation and then they are freeze dried. Then the other part is the vacuum dried, and the fourth one is the Procera. These are the Procera which has a contact lens along with the amniotic membrane. So there are different methods of application of the membrane. One is the graft, the patch, and the sandwich. The graft is nothing but it is used as an inlay, as you can see in this picture. Whenever there is a defect, it just fills up the defect and the epithelium is formed over the membrane. So the amniotic membrane gets integrated in the corneal tissue, that is the corneal stroma. When it is used as a patch, it is used as an overlay, that is the epithelium is formed underneath the membrane. So these are the different indications in which it is used. So overlay is commonly used for burns and chemical injuries, especially above the grade 4. And it is also used for acute SGS cases in the hospitals and for pseudophakic bullous keratopathy and for persistent epithelial defects. The sandwich technique is nothing but a combination of both patch and graft when it is used for cases of corneal perforation. So normally it is used for sterile perforations, but in some cases of perforations when there is minimal infection or minimal infiltrate, this can still be used. Coming to one case I will like to share. This is a 50 years old female patient who is a known case of rheumatoid arthritis and positive for RA and CCP antibodies on immunomodulator therapy. These are the medicines the patient was already on, which were started elsewhere. The best corrected visual acuity in the right eye was 20/320, and the Seidels test was positive in this patient. As you can see in this picture, you can see a central area of perforation, which doesn't look like an infiltrate or there's no infiltrate. So, and the surface, ocular surface is also looking very dry, and the patient also has some cataract. And the iris is adherent to the endothelium, and in fact, there is some iris exposure through the perforation site. So, in this patient, we planned for amniotic membrane grafting in a multi-layered fashion. And this was the This was the picture after 2 weeks of post-op. So there is a video which I will share.
Thank you, Dr. Prajakta.
Yeah, is there any time? I will share the video if there is any time.
Yeah.
So I'll share some other video, which is a little larger perforation, which was done in HSV case. Is it visible?
Yeah, it is visible. Please go ahead.
Yeah. So this was a HSV patient in which there was a perforation. So centrally the vitrectomy is being done, and the epithelium is removed from the sides, and the vitreous is also, they are checking with the iris repositor whether there is any vitreous at the edges of the wound. Then after putting fibrin glue, this is the AMG, which is removed from the nitrocellulose paper, and one layer of the AMG is then placed along with the glue. Then there are trimming of the AMG according to the size of the perforation, and some part of the AMG is being tucked inside the edges of the perforation. Then they have taken another AMG, another amniotic membrane, which has been then folded in different layers. And so this is a technique in which they are showing how to fold the amniotic membrane. So this is folded twice, and So depending upon the thickness of the amniotic membrane which you get, the folds can vary. Then according to the size of the perforation, these folds are created. And then this amniotic membrane is sutured after sticking it with the fibrin glue. So there are different types of sutures which can be used. There are infinity sutures in which you place the sutures in a cross manner. Otherwise, box sutures can also be placed. This is a technique in which multiple sutures are applied in a box fashion. I'll just postpone this video. So these are the box sutures which are applied for this case. At the end of it, a BCL has to be placed because it is difficult to tuck in these suture knots. So BCL gives avoids the pricking sensation which the patient can later have. So this is a good solution for when we can avoid keratoplasty in such cases, especially HSV. Thank you.
Thank you, Dr. Prajakta. Any questions on amniotic membrane grafting?
Swapnil, if I may, I just wanted to add to Prajakta's presentation. Thanks, Prajakta, for taking people through the subject. And what Prajakta was trying to show in the example which my colleagues did at LVPI was how even in the lack of, when you don't have corneal tissue, but you have a patient presenting with a large perforation, so amniotic membrane is extremely handy. And this multi-layer technique, so most of the time we use, for say, a chemical injury and so on, we use a single layer. But using this multi-layer technique, you can actually provide collagen and it can be a substitute for the stroma. So you can tide over the acute crisis. Many of the patients come into us with one eye only, and usually that one eye has this kind of problem. So this is a very good rescue therapy for these patients. So it's extremely important to learn this very simple technique.
Madam, do you have a post-op photograph of this patient?
I'm not sure if Prajakta.
The first patient we have like the 2 weeks post-op only. The later on follow-up we don't have.
I'm sure we have
the case we presented. And
so this particular patient she showed was a case of multiple recurrent HSV necrotizing keratitis. May have also had secondary infection and came with just like literally a gaping hole and with the vitreous at the entry wound. So the choices was to do a large graft if this wouldn't succeed. So luckily this held, and a large graft would have had a bad outcome. So later we can pick up the patient for an optical graft.
Ma'am, is Tenon's patch also a good idea for this case?
For this case,
I mean, if you don't have any.
Yeah, probably not for this particular case, I think, Asmita, but Tenon's patch is probably most of the practitioners here are also using Tenon's extensively instead of amniotic membrane. But I still, as an old timer, like amniotic membrane because of its, it just staunches the inflammation. And, the unsatisfactory part of Tenon's patch graft, it doesn't provide collagen. So you always see it white and present all the time. It doesn't have its own resilience or its tectonicity in that way. But yeah, TPG is also an excellent alternative.
Because
may I ask?
Most of the general ophthalmologists, okay, this is the message that we should give is amniotic membrane grafts are available in iBanks easily, and you can store it even for 6 months and 1 year. It can be stored for the emergency use. If not, then a Tenon's patch is available, and I mean that's something that can be done if you don't
we
have
a talk on
membrane.
So Dr. Arpit presenting that.
May I ask
yes,
one
sir,
question?
Please.
Is it about, do we have a talk on chemical injuries also? Just want to ask one question about that. Okay. Ma'am, for a general ophthalmologist, most of the time faces these patients of chemical injuries. So at what stage of chemical injury case he should think of going on amniotic membrane in that case? Mention at what time? Is it because some indications whether the ophthalmologist should think that I should go for an amniotic membrane?
So,
yeah, sure.
Yeah, ma'am, you are muted.
Yeah, sorry. Yeah, no, that you were going to answer. So you can also go ahead.
Okay, so what I do usually is, if it is as per Dua's grading, if it is grade 3 and above injuries, and if you think that limbal is significantly involved, the conjunctival involvement is significant, then you can go ahead with amniotic membrane grafting straight away. From 1 to 3 grading, Dua's grading 1 to 3, you can just keep on regrading the patient every 2 to 3 days on medical treatment. And if you feel that the grading is not improving, the patient is still at the same stage or worsening, then you can go ahead and amniotic membrane. But the next talk is very relevant to this, that tarsorrhaphy, intentionally I put it here, along with amniotic membrane grafting in all these cases above grade 3 and above, the tarsorrhaphy is must. Only amniotic membrane probably won't work. The tarsorrhaphy is very helpful for these chemical injuries.
To answer the question for the general ophthalmologist, if you have the most severe kind of chemical injury where there's ischemia, and so that is at least an indication where you straight away go ahead and plan amniotic membrane. Then you have the mildest of case where there is a minimal small epithelial defect, then you don't do amniotic membrane. So what he said, as you start medical therapy, which includes corticosteroids, and then there isn't significant improvement, so I wait for a week. In some cases, at the end of 1 week, I reassess, and I might then go ahead with the amniotic membrane for these patients.
Swapnil, I have a question to ask.
Yes, sir.
So we are cornea surgeons, we have HOTA license. So people who do not have a HOTA license, are they allowed to use AMG medico-legally?
Yes, absolutely.
Yes, AMG doesn't require a HOTA license. So part of a tissue and not the organ which we are transplanting.
I have one question to ask.
Yes, sir.
Is there any difference between the fresh and cryopreserved amniotic membrane? Or the dried amniotic membrane?
Yeah, the dried amniotic membrane is quite difficult to use in terms of how it sits on the eye. It's like parchment. I've not used it much, but I remember having a couple of samples that we had way before. So I would say dry is available, but it's very difficult to use. In terms of fresh versus cryopreserved, fresh is, in theory, I think it's not prepared well enough. So in an emergency, I guess you would use it. But between fresh and cryopreserved is easy to get from most eye banks. So I think we should use processed amniotic membrane rather than fresh.
Right, thank you. We'll move ahead to next talk by Dr. Adit Gupta. He will be showing us the right technique to do tarsorrhaphy, which is a very, very important technique in my opinion for most of the ocular surface diseases. Wherever you really feel that nothing can be done, at least tarsorrhaphy would definitely work. So Adit, please go ahead.
Yeah. Can you hear me, Swapnil?
Yes, absolutely.
Okay. Good evening, everyone. It feels good to be a foreign body in the cornea session, and it feels even better to see that tarsorrhaphy is getting so much importance in a session which is dedicated to cornea. Now, I believe that tarsorrhaphy is one of the most underrated surgeries which a general ophthalmologist should know about. When I started my residency, I trained at PGI Chandigarh, and in the first month, my professor asked me, "Can you do a tarsorrhaphy? Have you learned how to do a tarsorrhaphy?" I said no, because I was more excited to learn about intraocular surgeries. And the reply was, if you can't protect the eye, you can't operate on it. So the next 3 months was spent on performing a lot of tarsorrhaphies in my residency, bedside tarsorrhaphies, breaking backs, and going ahead. But in the next few slides, in the next 5 minutes, I'll just show you how tarsorrhaphy is important as a therapeutic as well as a prophylactic tool, and how it is more important for us as ophthalmologists to master it, because even in general ophthalmology practice, we face these scenarios very commonly. Now look at this middle-aged lady who has undergone an entropion surgery erroneously. It's a misdiagnosis of ocular surface, ocular cicatricial pemphigoid. Now you can see that most of her eyelashes are inturned. She has developed punctate epithelial erosions. Luckily, there was no infiltrate on the cornea. And at this stage, performing another surgery would just add fuel to the fire. So what you can do here is a simple tarsorrhaphy so that at least the eyelashes do not invert inside and protect the eye till you start her on immunosuppression, perform a biopsy, and start her on definitive treatment, and then perform an entropion surgery. Second, this individual was a dentist by profession, had developed SLE, and because of which he had massive fluid retention and conjunctival chemosis. His conjunctiva is completely dry, which led to exposure, pain, and sensitivity. On the right-hand side, you can see after 3 weeks of suture tassorrhaphy, how his conjunctiva has resolved completely with copious lubrication and just closure of the eye. Thyroid eye disease, certainly we need to manage sometimes when there is exposure keratopathy along with infection, or in cases like this extremely where there is subluxation of the globe, where the globe literally pops out of the eye socket because of laxity of the ligaments and pressure behind the eyeball. So in such cases, tassorrhaphy acts as a rescue therapy where you can provide support at the lateral canthus and prevent any further subluxation of the eyeball, which can be disastrous in certain scenarios, till you perform a definitive decompression surgery. Last but not the least, one of the most common conditions for which we perform tassorrhaphies are in the acute stage of a facial palsy to protect the ocular surface and prevent dryness of the eye. Now, we all know I don't need to define tassorrhaphy, but it's a closure of the eyelid, which could be either temporary or permanent, and depending on the position and the materials used, can be classified further. How I'm going to show in this video is how we should stop using bolsters for tassorrhaphy. You know, in medical colleges, all of us are taught to use bolsters. But in the Indian scenario, if the patients don't take good, adequate care of these bolsters, it leads to a lot of bacterial cellulitis of the skin and erosion of the skin due to pressure effect. Now, before performing a tassorrhaphy, you need to know that the eyelid is split into two lamella, anterior, which involves the orbicularis and the skin, and the posterior, which is our area of interest while performing a tassorrhaphy. And the gray line is the most important zone. So once you see the meibomian gland orifices, that the posterior to it is the gray line and is the structural skeleton of the eyelid, which needs to be kept in our position for a permanent tassorrhaphy. Now, we have already discussed the indications of a tassorrhaphy, but there are a lot of indications, especially corneal indications, which is why it is very important for a general ophthalmologist to master a tassorrhaphy. Now, there are different ways to do a tassorrhaphy. You can do temporary taping, which lasts for a day. You can do a suture tassorrhaphy, which lasts from weeks to months. A chemical tassorrhaphy in the form of botulinum toxin injection in the levator muscle, which can last anywhere between 3 to 4 months, depending on the dose used. Or a glue tassorrhaphy by using cyanoacrylate glue, which is used to seal corneal perforations, which usually lasts anywhere between 2 to 3 weeks if you want a shorter effect. Now, this is a simple video of a suture tassorrhaphy which is being performed. This was performed. Now, before performing a suture tassorrhaphy, we should know that the eyelid, especially where we insert the suture, is very vascular. So if it bleeds a little bit, there is nothing to worry. Bleeding is normal. Just a little bit of pressure, 2 minutes. You can see in this case, when I was performing the tassorrhaphy, the needle has gone through the peripheral arcade, and so it can lead to bruising as well. But just a little bit of pressure at that area for a couple of minutes, and a patch should just resolve this. So here you pass through the meibomian gland orifices or behind it through the tarsus so that you get a good bite, and just tie a temporary knot. You can use 2 or 3 knots. This tassorrhaphy basically is for protection for 2 to 3 weeks. So this is a simple suture tassorrhaphy. You don't need to use bolsters, and you can cut it whenever you want. Coming to the workhorse, which is needed, where you need a tassorrhaphy for longer than a month's duration, is a permanent tassorrhaphy, which can be central, medial, lateral. Most often we perform laterally or paracentrally to protect the ocular surface and still have a view of the ocular surface and the cornea. Here, with a 15-number blade, you freshen the tarsal edge without destroying too many of the meibomian glands. You try to protect the meibomian glands because you don't want chalazions later on. And then once this edge is fashioned, you oppose these 2 edges with a suture of your choice, most preferably 6-0 Vicryl, so that it stays in apposition, and with help of secondary intention, the surfaces get opposed to each other. Now, this was a tassorrhaphy which we had recorded when I was a fellow at LV Prasad. Anesthesia is very fairly simple. You need to infiltrate around 1 to 2 cc in each eyelid. You can infiltrate along the skin side and also in the conjunctiva, because sometimes just infiltrating at the skin will not take care of the sensitivity of the conjunctiva and the ocular surface. So you can evert the eyelid or evert it on a Demar's retractor and slowly inject along the conjunctival side as well for complete anesthesia. Once this is done, then with the help of a 15-number blade and a Lim's forceps or a Pierce-Hoskins forceps, you can make an incision, and slowly, using a lamellar dissection, which we very well perform during SICS, you can just excise or create a raw area at the posterior lamella of the eyelid. Here you can see the meibomian glands also have been involved. And this then is apposed together with the help of a mattress suture, which can pass from above below or below above. Any that doesn't matter. It just depends on where you want to take the knot. And these two raw areas should oppose to each other, and they should stay in apposition for at least 2 weeks for the adhesion to form. After 2 weeks, usually vicryl sutures will fall off, or you can remove them if the adhesion is already formed. So this is how a suture tarsography is performed. But what I wanted to show in this video, in this session, is something which we have modified. It's also called as a serpentine tarsography. Now, this helps very well in patients with ocular surface disease, where you want to open the tarsography a little bit to see. So now in this, what we are doing is, with the help of a 4-0 Prolene suture, we usually use a thicker suture here. We pass the suture in a zigzag manner from the lower eyelid to the upper eyelid, just like a zipper. So you see, I'm passing the suture through the posterior lamella, through a bite is taken through the tarsus. I've gone from the lower eyelid to the upper eyelid, then I go back to the lower eyelid, and similarly, I go back to the upper eyelid till I come out at the lateral canthus. So this is the last bite, and here I'm out at the lateral canthus, and then I'll pass it again through the skin. Once the skin bite is taken, then you can tie a shoelace knot or a temporary knot so that you can open it and close it whenever you want. So every 2 to 3 days, you can open the knot. Now you see, when I pull either side of the knot, like a zipper, the eyelid will close on itself. So once the knots are pulled, you can see that the sutures have passed right from the upper to the lower eyelid. And once this is pulled, the tarsography and the eyelid closes like a zipper, and then a temporary knot can be used. This knot can be opened up whenever you want to examine the patient, and then closed again because it's a figure of 8 knot. So this is serpentine tarsography, which can be used. There are a lot of variations of tarsography technique. Some people have described a technique called as a pillar tarsography, where the tarsus is inverted, is transposed from the upper eyelid to the lower eyelid, and it can be released. This also provides adequate protection for mild ocular surface disease. Nowadays, we have been shifting to something called as a mechanical tarsography, where we use filler injections, which adds weight on the eyelid to protect further when maximal tarsography has been performed, as in this case, where a patient after tumor excision and ocular surface exposure, even after performing medial and lateral tarsographies, wish to have adequate cosmesis as well. So we did a filler injection for the upper eyelid, where we load the filler on the upper eyelid to reduce the exposure, and then you can spread the filler and then have a lowering of the eyelid by 1 or 2 millimeters. So this is another tool which general ophthalmologists can be used. It's just like viscoelastic injection and works very well in facial palsy patients as well. This was before on the left, and this is after the injection. You can see that the 2-3 millimeters of lag ophthalmos has reduced. Complications, usually notching is one of the commonest complications if you go too deep in the tarsus, and suture granulomas, which we see very often, respond very well to topical antibiotics. Gaping is common, but then you just need to redo it. Thank you for your patient listening.
Thank you, Adit. Any questions for Adit? Excellent presentation, Adit. No questions. So let's move on to next topic.
I just would like to highlight something which Adit has already told. It is very important to avoid bolsters. Use of bolsters has been it's very common everywhere. So we hardly ever see a patient who takes care of the tarsography and wound care very well with bolsters. So especially when you are doing tarsography for corneal problems where epithelium is not intact, you don't want to add some bacterial load additional on lids. So that is very important thing. And another thing, for permanent tarsography also, we need to, sometimes patients are very hesitant for permanent tarsography. So we need to tell them that we are not going to disturb the lash line, and anyways, whenever they're going to get back the orbicularis function back, we can just divide it, and it will still be very well cosmetically presentable. So just those 2 points.
Thank you, Adit. So next presentation is by Dr. Santosh Suman, who is going to present about the basic workup of the corneal ulcer and how to do corneal scraping in the OPD. So Dr. Santosh,
Thank you. Thank you, Dr. Swapnil. I hope I am audible.
Yes.
And as you requested, I have made it a totally video based,
Thank you so
and
much.
it has inbuilt audio also. So I hope it plays
Great.
and try.
The audio is it's not audible, Dr. Santosh. You can see video, but yeah.
It's not audible?
No. Can you try again? No, I think it's not audible. So can you can give live commentary as well on the same video? If at all there is some problem.
It's not audible, right?
We can see your video. Just you have to comment on that, I think. Commentary, yeah.
What I will do is we can proceed with other topics. I'll share it with Dr. Swapnil. I think he can play it from there. It's a small video. He will be able to download it in a couple of minutes, right? I'll send the.
So let's move
link.
on to Dr. Arpit, who is going to present about another technique of corneal perforation management, that is Tenon's patch graft. So Dr. Arpit, please go ahead.
Good evening, Dr. Swapnil. Is my screen visible?
Yes, it is visible.
So I'm going to talk on Tenon's patch graft. So corneal perforations are common corneal emergencies faced by all the ophthalmologists. Available modalities include use of tissues or glue where availability can be an issue. So Tenon's patch graft is an innovative, inexpensive technique for sealing moderate size corneal perforations. Common indications for these are viral keratitis, dry eye disease, primary Sjogren's, secondary Sjogren's, cicatrizing conjunctivitis, Stevens-Johnson syndrome, mucous membrane pemphigoid, and chemical injuries, traumatic perforations, peripheral ulcerative keratitis, healing microbial keratitis, and corneal fistulas. So I'm sharing a small video where we can see around 3 mm corneal perforation. So I am taking Tenon's graft out here. It is better to mark the area and cut it accordingly. So now desired size of Tenon's is excised. After taking the Tenon's, after dissecting the Tenon's, if you want to reduce the size of it, you can cut it or you can add more. Now taking overlay suture, infinity suture with 10-0 nylon. Here we can use fibrin glue as well for before taking the sutures under the Tenon's graft. So the approximately any small perforation to as big as 6, 7 mm, 8 mm perforations can be taken care by this technique. Only the way to take overlay sutures can differ, but Tenons provides very good and good strength to the perforated area. So after taking these sutures, we bury those knots, and making a side port entry, we try to remove the iris attachment to the perforated site and form the anterior chamber. During that time, sometimes anterior chamber can leak. The site where we have put tenons can leak, and we may face problems. So that time we can have some extra sutures there, or we can add glue, cyanoacrylate glue as well, or amniotic membrane can be used in such cases. So using iris depositor, I've tried to separate the iris and then form the anterior chamber. Thank you so much. Thank you.
Thank you, Dr. Arpit. Any questions on Tenon's patch graft? Meanwhile, I'll try to. Yeah. So, Arpit, you can stop.
Yeah, I'm already stopped.
Sir, I have one question. Is if we are doing a Tenon's patch graft, do we have to really tuck it in a little if there is a perforation, or we just keep it on the surface, flat on the surface? And the second question is, if you're putting a cyanoacrylate glue, can we directly put it on the Tenon's patch, or we put a drape disc and then put over it?
See, Arpit, can you answer, please?
Yeah. So if it is a small perforation, it is easy to tuck the tenon's tissue. But if in this case, if we try to tuck the tenon's tissue, I found it a little bit difficult. So I kept it and took the sutures and just removed the. But yes, you can tuck the tissue in, and about fibrin glue, you can just spread the fibrin glue over the tissue and then over the cornea, and then put tenons and then take sutures. Swapnil, you can add a few points if you want.
Yeah. So
I have a question.
Yeah, your question was about cyanoacrylate glue, right? So you can always put it over the tenons, but it will harden the tenon a little bit. And also, our aim of using tenons in place of cyanoacrylate glue is to have less vascularization, right? So this cyanoacrylate glue is again, going to induce a lot of vascularization. So it's better, if at all we can avoid. But of course, the primary goal always remains to seal the perforation. And if it is not getting sealed only with tenons, then you can always put cyanoacrylate glue. And it is not necessary to tuck in the tenons. You can just place it over the surface. Just overlay sutures has to be very tight and nicely put.
I have a question. Am I audible, Swapnil?
Yes, please.
Yeah, it was just related to what you just mentioned about the vascularization. So I also use a lot of tenons patch grafts, but as compared to cyanoacrylate glue, do you find a difference in the vascularization? Like initially, in some cases, I thought that the tenons induces less vascularization, but then there are many cases in which I feel it's just the same as the cyanoacrylate glue. So
I would say the deep vascularization is less.
Okay.
Which matters when we plan secondary procedures like PK or something like that. So deep vascularization is less compared to cyanoacrylate glue.
Right.
You will definitely have superficial vascularization because that's how tenons will heal, right?
Swapnil, a couple of points post-operatively when you do a Tenon's patch graft. The first is that initially post-operatively the graft will appear to balloon, and this will happen especially if it's in contact with aqueous, because it's not as stable. That's what I was talking about earlier also, in terms of providing a barrier to the aqueous. So it'll appear to balloon out and it'll appear to be more edematous and fluffy. So that doesn't mean that it's failed. You can, when you measure the eye pressure digitally, you'll see that the eye is well formed, AC is formed, the globe is well formed, and AC is formed. So it's not a failure. And the second is that the metabolism of Tenon's patch graft takes a long time, several months, or maybe even a year. I've had a patient where it takes a very, very long time. And the host healing tissue that will replace the Tenon's patch graft is extremely slow as compared to, let's say, if you've done amniotic membrane, or even if you've done glue Kunjal for that matter. So because of the vascularization, the healing, the reparative process, the tissue that comes is faster. So with Tenon's, it doesn't mean it's a failure. It's just a longer path. But I think it's an extremely good technique and works very well for these kind of situations.
Okay, thank you so much, Arpit. Can you just stop your screen sharing so that I can
Yeah.
share the next screen? Yeah.
Is this okay?
No, you're still sharing the screen, so I'm not able to share it.
Just give me
Rahul, can you help? You just need to do stop sharing.
Yeah, I did that actually.
You can still see your screen.
Yeah, I'm sorry. Just give me 1 minute. I'm sorry, I'm not able to do the.
Rahul, can you help? Is it possible at our end?
I think if you move the cursor to the top of the screen, that will pop down. The option will pop down.
Purple tiny icon that is there.
Oh, yeah, this one.
Yeah.
Top of the screen.
Right.
There's a purple icon with a screen and a man.
Yeah, I've done
Take
that.
the view options.
You
Yeah.
can leave the meeting and rejoin again.
That's the best.
That I can do.
Stop.
We can still see you, Arpit.
Just 1 minute. Just.
This scene is from where? Very nice.
Sorry.
Swapnil, we go with Santosh's presentation next.
Yeah, I'm not able to share the screen till he.
Or we continue with the perforations and cyanoacrylate glue.
Yeah, no. Problem is I'm not able to share the screen till the time he stops sharing the screen.
There is
Can
a
you
view
leave
option.
the presentation again, join back. The tech person is there. Rahul, are you there?
Or he
You
can
can-
just leave the meeting and again connect.
Last one, switch off the mobile or they switch off the MacBook, whatever you are doing.
No. So you can double tap on the. Okay.
Yeah, now it's done. Yeah. So I'll just share Santosh's presentation. So it's you can see, right? It's audible.
Corneal scraping provides the most valuable specimen in cases of infective keratitis for its diagnosis and management. Scraping is also done as therapeutic procedure for better drug penetration and sometimes to reduce the load of microorganisms. In adults, corneal scraping is usually done under topical anesthesia, and general anesthesia is required in kids and for mentally unstable patients. Though Kimura's spatula and calcium alginate swabs can be used to increase the yield of scraping, we generally use 15 number blade because it is disposable and it is easily available. I usually scrape on sit lamp, but if you have a facility of operating microscope and a recliner in your OPD, there is nothing great like that. Commercially available glass slides have dirt and smudge over it. So we clean glass slides with alcohol and keep it wrapped with aluminum foil. I usually cover the wrapper of 50 number blade to make it like a handle. You can also use a BP handle for that. After sit lamp focusing, I use the thumb of my left hand to hold the upper lid and use my right hand for the holding of 50 number blade. The illumination arm of sit lamp is moved towards the left side as I am a right-handed person. My OPD staff makes sure that patient is comfortably seated, the chin and forehead is properly touched to the chin rest and headrest of the sit lamp, and staff also makes sure that the patient does not lean back. Classically, scraping is taken from the advancing margin and base of the ulcer. But many times we have to modify it according to the type of ulcer. For example, in this patient, there were 2 foci of infection, and we had to take sample for at least 2 slides and at least 2 cultured media. So we scraped from both the sides and took sample twice from there. So these are the supplies required for basic microbiological workup: a lab microscope, gram stain kit, KVH stain, 15 number blade, glass slides, cover slips, a permanent marker, and few cedar oil or paraffin oil bottles. KVH is available as pellets. For preparation of 10% KVH, we have to add 1 gram KVH, which is about 8 to 9 pellets, with 10 ml of sterile water and a few drops of glycerin. We usually keep 10% KVH in an eye drop bottle for easy application. Gram stain is commercially available in bottles. For the ease of application, I keep these in 10 ml eye drop bottles labeled as 1, 2, 3, and 4 in the sequence of applications, so that there is no confusion, as the staining is done by my hospital staff. The scraped material is smeared over slice and the blade is covered by its wrapper and thrown securely. With the help of permanent marker, both the slides are inserted on the back side to mark the location of the sample and labeled as MR number, name, etc. on the front side. For gram stain, we have to smear the sample over the slide, whereas for KVH stain, we just have to put the sample over the slide, put a drop of KVH, 10% KVH, and then apply cover slip. Remove the excess KVH by pressure, and then the slide is ready for viewing. Viewing is started on the lab microscope with 4x magnification and gradually increased to 10x and 40x magnification. Whereas for gram stain, after fixation, smear, and staining, we have to focus on 4x magnification and then directly switch to 100x while immersions. If you want to photograph your bugs, you can use your mobile camera over one of the eyepieces. As I have to take pictures frequently, I have made a small adapter which provides fixation and fixed distance from the eyepiece so that I can take pictures quickly. This is how we plate the samples on blood agar, chocolate agar, and SDA. These are sent to microbiologists. Labeling on culture plate is done on the culture media side, not on the cover side, because cover might get interchanged. Those comprehensive ophthalmologists who are treating corneal ulcer and are not having a lab microscope, for them, my humble appeal is that they must own a lab microscope. Please start with only KVH stain, which hardly takes few minutes. It will make a huge difference in the confidence with which you treat corneal ulcers. Thank you.
Okay, thank you so much, Dr. Santosh. Any questions to Dr. Santosh?
Swapnil, can I make a quick comment?
Yes, ma'am.
Santosh, excellent, and I'm sure Dr. Savitri Sharma would be very proud of you after seeing your presentation with all the tips. You know that we also use trypan blue, so just the same old trypan blue that we use for staining for cataracts for the anterior capsule. So in the KOH mount, you can just add a couple of drops of trypan blue, and that stains the fungus, acanthamoeba, and even microsporidia, and that really makes it very easy. So for the general ophthalmologist or even for the cornea specialist, it makes it that much easier than it is for the microbiologist.
Very true.
May I ask one question?
Yes, sir.
Yeah, Dr. Santosh, most in my setup actually, whenever I do a scrapping, then I send to a microbiologist. We call them. Somebody came from his lab. I want to just, is it advisable to put a KOH drop on the as soon as we take it, and then because the person will come maybe after half an hour or 1 hour after that. If the sample gets dry, is it would be a problem in the examination? What is advisable? I think.
So my answer would be as my last statement was that everyone should have one lab microscope. It's hardly 25,000 or 30,000, right?
It's not a question of money, but
it doesn't take more than 2 minutes to see a KOH. But anyway, if you want to send your samples, it's better to put one drop of KOH and put a cover slip over that, so that there is no chance of contamination also. But also there is there are some times when you have very minimal sample and you might not able to get samples on 2 slides. So if you have just one slide, I think your microbiologist would prefer not to stain with KOH. So my microbiologist suggests me that just put saline. So we call it saline preparation. We just put one drop of saline and put a cover slip over that and send it to microbiologist whenever we have minimal sample. So you better consult with your microbiologist what is their preference and do according to that. Because anyway, if you are not seeing it by yourself, you are dependent on them. So
I'm sure, but in a practical scenario, I'm sure very few ophthalmologists must be having, besides the institution, in a single private practitioner. At least in Amravati, I don't know anybody not as a cornea specialist.
We have in fact
general ophthalmologist.
Sir, I'm in a private practice and I see all highlights myself.
You're a cornea specialist.
We have to take wet lab for that, so we can learn from these stalwarts. And I think I don't know about cornea, but for retina people, that is the need of the hour, because we have to inject. We have to decide about the antibiotic and as well as the steroid, whether to inject in endophthalmitis case. And to rule out fungus is very much important. We have to take that decision very fast, instantly. So that is the need of the hour. I think we should have that lab.
So one stain KOH stain, it doesn't take much time. At least you can know whether it is either fungus yes or fungus no.
Yeah,
so
yeah,
your treatment line changes a lot. Fungus yes or fungus
sure,
no. At least you can start with that, and then you can move on to Pythium and other things.
But don't put the drop of KOH, sir, Dr. Atul. Yeah. You should just send it dry.
Saline preparation.
Or even saline, but it's certainly not KOH. When you put KOH, and if the microbiologist is seeing it after some hours, if you have acanthamoeba, they'll actually burst under the swelling pressure. So ideally, you shouldn't put KOH.
Sir, one question, ma'am. What is your experience about a microbiologist? Whether they are well versed with our ophthalmic micro evaluation or not?
So you have to collaborate and both. It's a bilateral learning. You have to train. You have to sort of have somebody who has an interest. You have to find a microbiologist who has an interest in seeing minuscule. They're used to seeing this much of material and full of pus and things like that. So when you send an ophthalmic specimens, they get highly frustrated. A general microbiologist. So they have to have that patience, and once you have to. That's the reason, as Santosh was saying, that we should first know about the bugs. And then we can train any microbiologist because they know how to read bacteria, fungus, acanthamoeba, everything. And if we are able to show it to them in that small, tiny sample, then they're smarter than us and they understand how to do it.
Okay.
Santosh,
may I ask a question?
General ophthalmologist. I think it's not fair that a general ophthalmologist would keep a microscope in in their practice because they may not be seeing that many ulcers. I would say depending on the load.
Ma'am, they see more than us sometimes.
They see more than us. Yes, they see more than us.
They see more
They
than
see more than
you,
us.
but they don't want to treat it. They want to refer it to you only.
I just be practical.
They don't want any headache.
That's good.
Yes. So let's go. Yeah. Any question?
Please go ahead, Asmita.
I have a question to Dr. Santosh. What about the culture plates? Whenever needed, do you stock them, or whenever needed, the microbiologist
So
sends it across?
I mean, my microbiologist sends culture plates in bulk, and we keep it in our fridge, in the same fridge where we keep corneas and all, and we use it. It can be kept for a month, so nothing happens. Whenever we want to use, we use it. Like mine is a cornea setup, so I have at least 4 or 5, minimum ulcers daily coming, so it gets consumed easily. Not a problem. You can keep it for a month.
Yeah, that's what I'm doing, and I had to go one step ahead, and I actually bought an incubator because for me transporting the plate, the nearest microbiologist for me is 80 kilometers away, and then cost factor comes in where you send and then there's a report which is no growth. So I kept an incubator which hardly costs 5,000, and then I keep the plates. If there is growth, I send it to the microbiologist. If not, then I know there's.
So we all
no
have to
growth.
improvise according to our, setup, or whatever is, available with us. I know a cornea surgeon who is very famous, and he says that he never, sees it by himself because, the microbiologist is just one shop away. So, why to see by yourself? You just send it. It's just one shop away. So you have to decide according to your setup.
Right, let's move on for the next presentation by Dr. Purva Shah. Is about use of cyanoacrylate glue in management of corneal perforations. Please go ahead, Dr. Purva Shah.
Yeah. So I hope the slides are visible.
Yes.
I take this opportunity to thank Maharashtra Ophthalmological Society for this webinar opportunity and Dr. Swapnil for letting me be part of this session. So basically, this is we've covered Tenon's patch graft, we've covered amniotic membrane and multi-layering of it, and now we'll come to the humble cyanoacrylate glue also, which is actually a cheap and very easily available alternative and can be very readily useful or utilized by the general ophthalmologist in case they see a tiny perforation, which is actually it is an ophthalmic emergency and can be treated before referring the bigger ones. So it's basically a synthetically derived glue, and it is basically it polymerizes as soon as it comes in contact with the weak bases or water or tissue as such on the surface that it is applied, and it becomes like a solid. So where exactly do we use these? So what are the indications? Basically all those tiny perforations of 2 to 3 mm where it could be because of a sterile melt or a trauma, or in cases where there's a healing infective keratitis where there is also melt present and stromal keratolysis is going on. All these cases are amenable to cyanoacrylate glue application. If you've removed a very deep foreign body from the cornea and suddenly you see that there is some amount of aqueous seepage, then again this glue can come in handy, and it is commercially available. In cases of peripheral melts or peripheral ulcerative keratitis, again we use it very extensively to give tectonic support to the peripheral cornea and gives great results and stays there. And sometimes in cases of limboscleral tears or corneal tears where even after repair there's a subtle leakage which is seen, and it's a complex tear or something, and there's a tiny leakage, a tiny bit of tissue adhesive can come to the rescue and the bandage contact lens can be placed. Similarly, for us cornea surgeons, we also use it extensively in cases where we see that there's a large melt and before trephining, and where the AC is totally gone and there is a very soft glow before trephining, we can place in a patch of drape, a sterile drape, and then actually do the trephination in an intact globe. So what exactly does the cyanoacrylate or the tissue adhesive do? It polymerizes in contact. It is in a liquid form and it polymerizes as soon as it comes, and these spicules form on the surface within seconds. It usually has a bacteriostatic as well as a fungistatic effect. It has been shown and documented and published too. It inhibits the collagenolisis and the melting underneath it, and inhibits the attraction of the leukocytes towards the wound. It interferes with the interaction between the newly forming epithelium and the stroma, and attracts blood vessels, which actually leads to faster healing. So this is the commercially available formulation. It is in the form of isoamyl cyanoacrylate. It is approximately 500 rupees in these days, and it is in the vial of 0.25 ml. And this is how it comes. There is a syringe, 1 cc syringe, as well as a glass vial, and there's a needle to withdraw the thing. And what else do we need? We need a 15 number blade or a tooth forceps, as well as we need a bunch of Merocel or Excel sponges. These come with the tip here of a sponge spear, as well as the blunt base, which is made up of plastic. And this is a very nice demonstrative video made by a very skilled fellow back in LJ Institute, which I would like to share with you. This is the kit, and under aseptic precautions, we withdraw the liquid into the 1 cc syringe as shown here. And this is again a case of central corneal perforation. As you can see here, it is a central leak, and we can elicit the Seidel's test over here, where you can see the aqueous gush which is seen. And so this is kind of diagnostic of the perforation. The fluorescence is seen with the aqueous flow. Now what happens is we just take a 50 number blade and scrape the epithelium around it very gently, the perforation, so that the glue, which is now going to polymerize, gets a base to stick to and then bridge this perforation. So this is the removal as well as the debridement of any debris which is present. The back of the spear, as I showed you, is touched into this drop of the cyanoacrylate glue, which is placed onto a sterile surface like the inside of the sponge packet that you open. That is, again, we can utilize it, not preferably any cotton or cloth surface. So this is the plain surface on which the drop, in which the back of the spear, which has a uniform bend, which is placed over it, and 2-3 times the back is now tapped onto the plain or dry area where I'm sorry, this is, yeah. So here was the debridement, and yeah, this is the tapping to make sure that the bulk of the tissue adhesive is not present at the back, and it's just a tiny thin uniform layer which is now ready to be placed onto the surface of the perforation. So here we are doing the drying of the surface, and just it's lightly touched and immediately removed. So you see, within an instant, the glue has crystallized, and this is what it looks like. And this is the view, and the aqueous is no more coming out. This is another case of a peripheral corneal melt where the perforation is there. And here again, the debridement is done, and the tissue adhesive is placed such so that the limbus is not touched, and just the area where the tissue is applied, there's a thin layer of tissue adhesive over there. Sometimes there is also a case where there might be continuous leakage of aqueous, and there you need to take the patient in the OR, and under the AC might be flat. And as you can see here, the anterior chamber is absolutely flat, and so we have to form the anterior chamber first using maybe air with this 29 gauge needle. And then while you're coming out, after placing the air bubble inside the anterior chamber to form it and to seal the internal lip of the perforation, because we want to prevent any leaking further, we need to place a bud over there to prevent the air escape. And gently, when we come out, then the air is retained inside. Again, we do the gentle, careful debridement over the surface. And now we can see the aqueous gush is suddenly controlled, and it's more amenable to placing of these tissue adhesive. So here again, we make sure that there's no pressure applied over the globe, and drying is of utmost importance. And here the iris is again removed from underneath in case there is any adherent iris tissue, and then in case it is still leaking, you can place a patch of a sterile drape over there and then place the tissue adhesive over that. So again, that is providing the tectonic support also. So these are the various methods in which different types of perforations can be handled at the slit lamp or within a minor OT kind of a setup. So this is what I wanted to highlight. And the bandage contact lens placement is very important, because then that is something which prevents any foreign body sensation, and the patient becomes very comfortable, because this glue is actually very hard and causes a lot of irritation in the eye. So what are the points to remember? Basically, it's just for a very tiny perforation, as we have seen that larger perforations are more amenable to amniotic membranes as well as stain and patch grafts. And epithelium should be debrided, because the glue won't adhere to the intact epithelial areas. And the floor area should be absolutely dry, and the sponge helps quite a lot in that. We don't use the buds, because then the cotton fibers might adhere and they might stick along for the longer period of time. Application should be absolutely quick, as we see, and immediately removed to avoid any kind of spicule mounts coming over there. And thin uniform layer of TA should be applied. It should not be bulky, so that the anterior corneal curvature is still maintained. Bandage contact lens is a must after tissue adhesive, and you'll realize if the bandage contact lens of that patient dislodges, immediately the next day patient will come to you and say he just cannot open his eyes. So that is important. We prefer not to let the tissue adhesive, as it is in a liquid form, touch the limbus. And tissue adhesive is not to enter the anterior chamber. It is a toxic substance, so preferably intraocular penetration or contact should be avoided. And yes, we do not need to apply any pressure patch to try and form the anterior chamber once the tissue adhesive has been applied. So do not put in a pressure patch after you've done a tissue adhesive glue application. And if it's still leaking, then we might need additive procedures on the cornea, and maybe even use of corneal patch grafts and tectonic PKs. So tissue adhesive as such, we've seen that it is a foreign material. So we have to let it do its work, and then what is the optimal time of removal? Usually when it has done its work and the stroma underneath has healed and the epithelium underneath has grown back, this loosens off and it is dislodged. But if we see that there are a lot of vessels coming up and it is still not loosening, we can check by removing the BCL. We can just check if it is starting to become loose, and that is, if it's not loosening up, do not try and forcibly remove it, because the healing is still taking place. Depends upon the pathology with which we are dealing, which has caused the perforation. So it might take a longer period of time. I would like to thank you for your patient listening. Thank you.
Thank you, Dr. Purvasha. That was a nice presentation. Any questions, Dr. Purvasha?
One question I have, madam. I got one experience that somebody had applied his cyanoacrylate glue, and patient got a lot of pain after that.
Yes,
And
sir.
I think some infection element was there. So in that case, what is to be done?
So if there is a lot of glue and it is in a bulky way that it is applied, then it actually acts as a growth medium for those surfaces which are now protruding above the corneal surface, and the tears are not able to wash that area. They act as conduits, or they act as reservoirs for infection. And so I think that is why I'm saying just a very thin layer is to be applied. And do not go again and again trying to seal that perforation. If it doesn't happen, then just leave it, and we need a better tissue additive procedure. Not cyanoacrylate glue will not help. So in those cases where cyanoacrylate glue application itself is causing microbial keratitis, I think we need to remove it, send it for culture, treat it accordingly like a proper microbial keratitis. And these sometimes these whitish mucopurulent discharge gets collected underneath it also. So we need to take care and we need to go underneath the PCL and remove those membranes or discharges also. So that way, hygiene of the patient is important.
What
May I add
medicines are
something here?
prescribed post cyanoacrylate glue? What
Yes, sir.
medicines?
So primarily the pathology that is responsible for the perforation, we take care of that. So if it's a infective melt, then those particular antibiotics. But in general, if it's a sterile melt or other cases, then a prophylactic epithelial friendly broad spectrum antibiotic can be prescribed 4 times a day, like maybe moxifloxacin. And our best friend is the chloramphenicol ointment. So that again is once or twice a day can be applied. So that takes care as long as the bandage contact lens is there. So that again is a source or reservoir of infection, potential infection. So we don't want that to happen. We need to change the bandage contact lens every once in a while, maybe in 4 to 6 weeks, depending upon how the tissue adhesive is faring. Yes, Asmita.
May I add 2 points regarding the pain after cyanoacrylate glue application is it is very toxic if it comes in contact with the iris. So if it has been applied when there has been a little iris prolapse, or if some glue has seeped into the anterior chamber, that will cause a very severe uveitis or a toxic reaction. Or second thing that can happen is if it has been a long perforation for a long duration and if the iris is really plastered, the patient can go into pupillary block once you close, because that was acting as a leak. So the IOP was kind of okay, but once you seal it, the patient may go into pupillary block and have a severe. So a raised IOP has to be checked at least digitally when a patient presents with severe pain after glue application. Thank you.
One question, ma'am.
Yes.
You showed one way of application of the cyanoacrylate glue. Does everybody follows the same, or is there any various ways of applying the glue? Directly one drop at the site through the needle, something like that, or that? What is the most safest way to apply the way you showed? Like
So
that.
like the one that we have a circular, it also depends upon the configuration of the site that we are trying to apply it to. So here it was absolutely circular and central. So there just touching a circular back part of the sponge sufficed very well. Sometimes we need to glue the areas where the keratoprosthesis is melting. The carrier graft of the keratoprosthesis is melting. It is between the cylinder as well as the graft. So we go in with a 26 gauge needle. We just dip it into the glue. We just tap it again and just go beneath the cylinder and then apply it. Again, that the idea of putting a drop of cyanoacrylate glue is too much, sir. That is a very bulky drop. Actually, it's too much. We just need a very very tiny thin film of tissue adhesive over there, and that's it. That takes care of the thing. And in cases of peripheral corneal melts, we need multiple applications all along. So sometimes if that circular part is too broad for coverage, then we also use the 15 number blade also, and we just tap it over the tip and place we just basically make sure that all the tectonic support is reaching to the areas which are thin.
In case of non-perforating corneal ulcer, madam, is there any indication non-indolent ulcers not responding to your treatment? Is there any role of cyanoacrylate glue application?
So we have to find the
Impending
reason.
perforation.
Impending perforations, if it's more than 90-95%, then preferably give it some support. That won't harm. But we need to find the reason for the persistent epithelial defect or the neurotrophic cornea if it is there. And then additional measures like tarsorrhaphy, as has been discussed, might be needed. Autologous serum and bandage contact lens and frequent lubricants. Again, we need to find the pathology and treat it. This is just for emergency use.
I would like to add one point. Like sir asked about any other technique for applying the cyanoacrylate glue. Like simple or cotton bud, the plastic part of it, if we just fold it, then it can also act as it will help in just applying the part of cyanoacrylate glue.
Good idea.
Not tried it.
Thank you, everyone. So let's move on to next presentation by Dr. Seema Mane. The presentation is about using intrastromal and intracameral voriconazole to treat this recalcitrant fungal.
Recalcitrant fungal infection. Yes, thank you, sir, for this opportunity. Good evening, everybody. I will share the screen. This is an recorded. Is it visible?
Yes, it is. We can't hear it though. Is there any audio?
It is not audible.
No, you can just go ahead and give live commentary. That is not the problem.
Okay. 1 minute. Just let me decrease the volume. Okay. So this is about the technique of intrastromal voriconazole. So first, I would like that this is not an only treatment. So it is an adjuvant therapy, not a replacement therapy. There are defined criteria and multiple injections. It may be need to repeat it multiple times, and always we have to explain the guarded prognosis to the patient. For the same patient, you may need to repeat the intrastromal injection 2 to 3 times. So it is given usually non-responding ulcers if you have tried for 2 weeks of minimal topical therapy, deep stromal recalcitrant infection where you don't expect the other drugs like natamet to penetrate. As you know, the limited penetration of natamet is there. Stain and culture proven. And in these 2 weeks of topical therapy, even if you have tried the voriconazole, that also, if it is not responding, then you can go ahead with the intrastromal injection. Exclusion criteria, obviously, if it is an anterior stromal ulcer, you can straight away treat it with the natamet. Impending or perforated ulcers are there, total corneal ulcers, scleral involvement is there, or endophthalmitis cases. So these are the patient, like if you are giving them a maximal topical therapy and if you want to give something else, then this can be tried as an adjuvant therapy. Not like in these cases where it is a total corneal ulcer is there, lot of hypopyon is there, then better to go ahead with the TPK in these cases. So the preparation of intrastromal voriconazole, it has to be done in the OT. 1 mg white lyophilized powder is available in the glass vial. It is reconstituted with 2 ml of distilled water. The concentration is 0.5 mg per ml, 50 microgram in 0.1 ml, and it has to be loaded in 1 ml tuberculin syringe, and 30 gauge needle is to be used, the yellowish one. It helps in better visualization or penetration through the stroma. So there are less chances of perforation while giving these intrastromal injections. So there are multiple preparations available in the markets. So this is the one, no financial interest. So it is directly available. You can add the 2 ml in this. Even a voriconazole eye drop. These are the powders, 200 mg. So you have to dilute to form the concentration of 50 microgram. So this is the technique. 1 ml syringe is used. So initially I have done the side port. The hypopyon was there. The AC wash was given, and the form the chamber properly, little bit on the hypotony side. So there should not be any air in the needle hub. Go parallel to the ulcer, away from the ulcer. At any point of time, your needle should not touch any part of the infiltrate. Give the injection 360-degree around, and just you have to hydrate the stroma, and that hydration should reach the ulcer at that point. And if you see, the bevel end is directed towards the ulcer. So there is how you are directly giving that drug depot injection in that infiltrate. And as that hydration reaching to the infiltrate, so it is giving more of drug at that site. So mostly cover it from the all side as much as possible. And then you can give the intracameral voriconazole, Vigomox, and then hydrate the wound. So this is how it is done. I think that's it. Thank you. Am I audible?
Thank you, Dr. Yeah, we can hear you. That was excellent video and good demonstration of the technique. Yeah, any questions about intrastromal voriconazole administration?
Sir, one question I have. We are giving at the periphery of the ulcer. So, do you feel that it will take care of the central part of the ulcer?
No, not really, because it will just take care of the spread of the ulcer.
Yeah.
Not really, because spread of the ulcer would be from the periphery, right? But that's what she said, that it's an adjuvant treatment. It is not the mainstay of treatment. So
We
you
have to
reduce
continue the topical.
Typically, you have to continue.
Then why not we feel to inject in the center of the stroma?
You
What
can,
is the
but there
harm?
would be thinning, right? In such severe ulcers, there would be a lot of thinning, necrosis. You won't be able to really retain you won't have that much of the stroma to inject voriconazole. You might land up with perforation as well. Yeah, Kunjal, you are muted.
Hi, good evening, everybody. Am I audible, Swapnil?
Yeah.
Yes, yes.
So
Okay,
Kunjal is
at
going
the
to
outset,
present about, can you, she's going to present about use of punctal cautery, which is again a forgotten technique, which is very, very important in case of Sjogren syndrome and other SJS dry eyes. So I just requested her to present that so that everyone can, start doing it in their own practice. Yeah, Kunjal, please go ahead.
Yeah. Thank you, Swapnil. At the outset, I'd like to thank Swapnil and Maharashtra Ophthalmic Society for this opportunity. So I'll be talking on a very simple topic as called punctal cautery. So we all know that surgical occlusion of the punctum is very important in moderate to severe dry eyes, whether you use punctal plugs or cautery. So what is the problem with punctal plugs in severe cases? Punctal plugs in general need a very appropriate sizing, and they can fall off easily. And supposing, if you put it in the intracanalicular ones, they can migrate, and then you really don't know how long they are there in the eye. So you really don't know what's happening if the patient is not improving. Whereas with cautery, you very well can see the punctum which is closed, occluded very well. And also, if it opens up, then you know that, now it's not working, and you can go ahead and repeat the procedure. So it has been shown that thermal cautery is definitely a very well-established procedure. Is being used for several years now, and it's better than using argon laser for closing the punctum. So the indications are basically aqueous deficiency dry eye, which is very severe. That is, the Schomers has to be less than 5 mm. So you have to have a patent lacrimal system. The syringing should be done prior to verify that. And you should have a patient, definitely, it's not like you just have low Schomers and you're going ahead and closing the punctum. The patient will obviously, it has to correlate with patient's severe symptoms and a lot of staining of the ocular surface, which is not improving with all your topical medications. So
Kunjal,
you cannot work. Yes.
your slides are not visible. Are you going? We are not able to see your slides. The only single slide is there with.
Oh, is it?
I think your PowerPoint is not on.
Even now you're not able to see?
No.
Oh, I'm like 3 slides ahead. Okay, one
That's
minute.
okay. You can just show the video now.
Yeah.
Are you able to see?
No, you can just unshare the screen and share it again so that,
Okay, I'll stop and restart.
Yeah.
Kunjal, you'll have to stop the other tabs which are open.
Like what?
Your desktop. Now we were able to see. You can click again. Share screen.
Is it visible now?
Your screen is visible, but not slides. We are stuck on the Explorers.
What could be the reason? Is there a support person? Is there a support person here who could tell me what could be the reason?
Are you there?
मिस्टर राहुल जी, आप कुछ बता सकते हैं, क्या कर सकते हैं यहाँ पे? Yes,
Okay. अब क्या करना है? Okay, so should I? Okay, should I change the route? I'm on Wi-Fi. Okay. नहीं वो ऑडियो इसमें नहीं है, ऑडियो नहीं है इसमें. ये अभी ठीक है?
Now it's visible.
Okay. हाँ, but ये सब मैंने ऑलरेडी बोल चुकी हूँ.
No problem.
अभी ठीक है?
Please go ahead.
Yeah. So this is visible, right?
Yes, this is.
Okay. Okay. So, so the contraindications for cautery is having an infection, or when the eye is when the ocular surface is very inflamed, then you have to wait for some time before you do the cautery.
Then you are stuck. Yeah, video is stuck.
So practically, okay. So practically, the indications of punctal cautery in our practice is severe primary and secondary Sjogren's syndrome and Stevens-Johnson syndrome. The role in neurotrophic keratitis and superior limbic keratoconjunctivitis is also there, but it's very limited. So in my practice, is mainly primary and secondary Sjogren's syndrome and chronic SJS if the punctum is not already occluded. So you need to use a monopolar cautery for cauterization. So you can use any monopolar cautery which is commonly used by the oculoplasty surgeons. It can be Basco or Elman or whatever you have available. So you can take the finest tip which is available, and you have to make sure that the cautery settings are put to the lowest, and you have to keep your cutting off, and the only the coagulation has to be on. You have to complete the circuit by putting the diathermy pad below the patient's thigh with the jelly. And then you have to start with the local infiltration. Is the video playing? So after you drape the patient, you have to cauterize. You have to place local infiltration, at least put 1 cc of local infiltration around each punctum, and then enter with the cautery tip. And you can start the cauterization and wait for complete blanching around the punctum and then slowly come out. After this, you just have to apply an antibiotic ointment and you're done. The same procedure is repeated on the upper punctum. Was this video playing?
Yes, it was.
Okay. So supposing you don't have access to a unipolar cautery, which we ophthalmic surgeons use, but you are in a multi-speciality setup, then even the general surgery cautery, which is used, comes very handy. So in this also, you have to do the same thing. Basically, keep the settings very low, only coagulation mode, keep the cutting off, and you can either use you can use a handheld cautery tip like this, but see that the end is very broad here. So what you need to do is that you can place a needle or a punctum dilator or a punctal probe. You just place it on the punctum and touch this cautery tip to the needle, and your work is done. You exactly have to do the same thing that you do with the other cautery. Also now, what we can very easily get online or with the dealers, local dealers, is a battery operated cautery. So you can remove the batteries and you can ETO the whole set. And then you have to, your sterile assistant can just open the cautery. You can place the batteries inside and then lock the cautery. After that, you can place the cautery tip tightly there and then perform the same cautery procedure that we discussed earlier. So after this, post-operatively, you have to explain to the patient that there might be a little bit of erythema around the lids. There might be a little bit of a pain for a couple of days. You can give them a painkiller. Topically, you can ask them to apply ice. That will help. And just give them a plain antibiotic and not an antibiotic steroid combination, because you want to induce the fibrosis. And you have to inform the patient that there's a chance that the puncta might open up in the future. If that happens and the patient still needs treatment, you can go ahead and repeat the procedure. And usually after a week to 10 days, you will start seeing improvement as the fibrosis sets in. So if you want to plan any procedure like a cataract or something, you should try and wait for a month, see how the ocular surface is doing, and then go ahead with the next intervention that you intend to do. So this is a case of a 57-year-old female who had a lot of dry eye for several years, and she was a known case of rheumatoid arthritis. She was treated with lubricating drops, cyclosporin, and she also gave history of punctal plugs which had fallen off. So on examination, she had a very severely staining ocular surface with mucus and filaments, and the Schirmer's was very low. So I went ahead and did the punctal cautery, and then over time, she improved very well. The Schirmer's course really improved. You may not see such a dramatic improvement in all cases, but what you can definitely expect is that the surface will get better, the patient will become very comfortable, the drops will reduce, and over time, the Schirmer's will improve. So she was doing well even at 6 months follow-up and continues to do so over several years of follow-up. This is another patient with chronic Stevens-Johnson syndrome who also improved very well. Although the surface still stains a little bit, but the patient has a dramatic improvement in the symptoms. Thank you.
Thank you, Kunjal. In the interest of time, we'll move on to the next presentation by Dr. Pankaj Lande. He's here. Pankaj, yeah, please go ahead.
Yeah, right.
To show us about.
First, I would like to thank MOS and Dr. Swapnil for the opportunity. Without wasting time, I will start my presentation on a very basic thing. So, superficial corneal foreign body is always, we all face all these situations. This is a small video demonstrating how to remove it and a very basic tips. These superficial corneal foreign bodies are audio visible? Small, fast-moving objects which usually arise while hammering or
Yes, but we can't see the video.
We usually. Oh, fine.
The video is also visible, Pankaj.
Come across many cases where these video voice is available. Superficial.
Yes. Yes.
Okay, thank you. Small, fast-moving objects which usually arise while hammering or while grinding work. We usually come across many cases where even after removal of these superficial corneal foreign bodies, especially if they are metallic, few particles remain there even after removal of a foreign body at base, and this keep on giving some reaction, causing more scarring and visual impairment if the pupillary axis is involved. To remove these kind of superficial corneal stromal foreign bodies, I usually use 1 ml syringe with 26 gauge attached to it, and it is bent in a fashion as shown in a photograph. The tip is also bent so as to prevent any injury to the patient while removing the foreign body. In this first case, you can notice the corneal foreign body is there and a whitish reaction is still there, and it can be very easily peeled off as it was there for 2 to 3 days. But due to oxidation, these iron materials get deposited in the center and these should be removed. I am using my 26 gauge needle as a shovel to remove particles from the base of this lesion. This way, I will be able to remove it without leaving any particles behind. Patient eye is anesthetized with application of a topical proparacaine eye drops. You can see there are ocular movements, and to prevent the injury to the cornea or inadvertent entry of this needle into the anterior chamber, the tip should be bent as shown in the video. In this second case, you can notice the amount of movement patient is doing, and I am removing the corneal foreign body. These are the cases where the needle bend is very important. As the tip is bent, you cannot injure the patient. After removal of a corneal foreign body, first take this particle out of the eye on a cotton bud, as that may get embedded in the fornices. Then the residual particles must be removed as shown in a video. Please note the movement of the needle and the application of force while removing it. We are not pushing the needle inside or anterior-posteriorly. We are trying to sweep it from above to below or from side to side to remove the residual particles. Foreign body removal on a slit lamp still has some limitations, and it cannot remove all particles even on best attempt. So these type of cases can be managed in OR under microscope with the help of a diamond burr. Patient is under topical anesthesia. A diamond burr of proper size is taken. It is battery operated instrument and do not have any sharp edges, so it avoids any injury to the cornea. Removal of such particles with the help of a diamond burr should be very meticulous and optimum, especially when the pupillary or central area is involved. There are many different heads available according to the size of a lesion. It should be selected very meticulously, and if you are using a diamond burr for this particle removal in the pupillary axis, just be very careful as not to use it excessive, as it can cause greater and may induce a cylindrical power. This diamond burr removes most of the particles from the corneal stroma without causing any damage to the cornea. Once this is done, application of antibiotic and home atropine eye drop is done and the patch is applied. Not all cases of corneal foreign body need patching, and it depends on individual's practice. Close follow-up is something which is must in these cases for initial 48 to 72 hours. I hope all these tips will help you in your clinical practice.
That's all about this presentation. This was a small tip about how to use this 26 gauge bent needle for corneal foreign body removal, especially in younger hands. Am I audible?
Yeah. Thank you.
Yeah, fine. That's all about the presentation. So,
any questions?
Any questions if there? I'm ready.
Okay, so let's move on to next presentation. I'm just going to share quick tips about doing corneal tattooing. Just a small video. So corneal tattooing has different methods. So I'm going to show multiple methods in the one video. So you can see in this particular patient, the mandatory requirement for corneal tattooing is removing all the epithelium nicely and then polishing the surface nicely so that you get a smooth surface so that it will epithelize better. So this is usually I use diamond burr for polishing the entire surface. Here I'm going to use two techniques. One is, I'm going to show two techniques in a single case. I'm making a tunnel. Here, like we usually do for lamellar dissection, I'm using crescent followed by this lamellar knives so that I can make a nice tunnel. So whenever you are using a tunnel technique, remember to make a tunnel which is from limbus to limbus so that the dye will stay in there. You can use the knives which we use usually for dissect so that it will, not perforate. It follows the contour of the cornea. And try to make it from limbus to limbus. Once your tunnel is made nicely, just you can use the cannula to push the dye inside. You can use the liquid dye as well as you can use the suit to do this particular procedure. And still, if you feel that additionally, the cornea is still not appearing very black and you need to do additional tattooing, then you can use the tattooing probe. I usually suture this particular entry because sometimes dye keeps on coming out for 1 or 2 days. And then I'm also doing surface tattooing over here. So this is the tattooing probe. All of us are by now aware about the probe. So it has this needle which moves to and fro at a very, very faster rate. So that's where it penetrates the cornea at a very faster rate. It has a guarded depth. So depth can be adjusted. And you can just move this tattooing gun uniformly all over the cornea. So this particular faster movement of the tip gives a very smooth and nice coloring of the cornea so that it will appear uniform. So after that you can just apply BCL. There are some variations. You also sometimes you get very bad corneas vascularized. So try to polish it nicely before doing tattooing because it's very difficult to epithelize. And then over that also you can spread the tattoo and use the tattoo gun. Similarly, you can also use it for localized polishing where there are localized areas of corneal scarring. So tattoo gun is an excellent you can also do it manually with the needle, but tattoo gun gives multiple number of pricks so that the tattooing is uniform. So as I said, try to remove all the mug on the cornea, try to polish the cornea nicely before doing tattooing so that it will get epithelialized nicely and it won't cause recurrent epithelial erosions. You can use of diamond burr for polishing the cornea makes it really smooth. So this is how tattooing gun is used. You can get this tattooing gun very easily on Amazon these days. And you can look at the uniform coloring of the cornea, uniform tattooing of the cornea. So that was all about tattooing. Thank you.
Just a quick comment.
Yes, please.
Just for the sake of the completion, I'd like to add that in addition to the liquid tattoo dyes, you can use India ink and soot already Swapnil has mentioned. And if you want to do a surface application of tattoo, then you can use gold chloride and platinum chloride with the hydrazine hydrate fixative.
Right.
Which tattoo is mostly used and where it is we can get it?
You can get it on Amazon, sir. I'll send you the link. You can get it on Amazon India Ink. And the tattooing gun also you can get it for 3,000-4,000 on Amazon as well. But only thing is nowadays these are not available as guarded with the guarded needle. So you just have to judge the depth of the needle yourself.
Is any company ophthalmic companies making
No ophthalmic companies. We had ordered all this from China, but now that dealer is not supplying anymore. So we have to go for the ones which are available on the Amazon.
Okay.
Sir, you also have brown color ink. I mean, you have all the colors available, but I have found that the black is too black and
brown is too faint.
Yeah, so now I've also tried a case where I mixed a little brown and black, so it's like you're using a palette, but then brown ink is available. So if you have a light colored, light-eyed patient, you can choose that instead of black.
The problem with the brown colors is that, you really don't know how it looks on the eye. Like even I have mixed in few cases both the colors, but then there are so many shades of brown, and then unless you have tried all of them, it's little difficult to judge how the brown will come out on the eye. So most of the times, unless it's a light brown iris, you will get away with this black. And only in the very light gray colored eyes, I think we shouldn't go ahead and do the tattooing. Like the cat eyes, that kind of color.
Are they come in sterile packs?
No, you have to ETO them.
Okay.
The liquid you have to autoclave. The liquid dye you have to autoclave.
You can also put it in the
also
syringes and autoclave it.
And also you can open a fresh bottle of some of the brands which are pre-sterilized, and then you just use little bit of what you want and then discard it or then reuse it within a short time.
Right, so that's all about today's procedures. Thank you so much, everyone. Excellent presentations, and everyone demonstrated it so well. Thank you, Dr. Vardhaman, Dr. Aditi, and everyone for opportunity to all the cornea surgeons and for letting us, giving us this platform. Thank you so much.
Thank
Dr.
you
Vardhaman,
so
on to
much,
you.
Swapnil. Yeah, thank you so much, Swapnil, for coordinating webinar, because I think this is going to be extremely valuable, especially for all the comprehensive ophthalmologists who can potentially do all these procedures and safeguard the patients. Of course, make sure that with all these pearls that they have learned today, they will do it in the right way, because there are a lot of comprehensive ophthalmologists who do it already, but because of not the right guidance, the patients are not getting the right kind of benefit. But I think today's webinar will definitely help all the comprehensive ophthalmologists. And of course, now this is recorded also. We'll be sharing this recorded link also with
that will be
everybody.
better. Yeah.
So that will help all the ophthalmologists as well. So now for the formal vote of thanks, I would like to invite the Secretary of Scientific Committee, Dr. Aditi, to please do the honors. Just before that, maybe Dr. Agarwal sir can give some concluding remarks. Yeah.
No, really, it was amazing experience, and we learned a lot. And I hope all the MOS member who are already doing this type of work, but they will refine their work. They can refine their work, and what are the do and don'ts, what are the nuances and intricacies in all those procedures. So I think now henceforth they can do it in a better way. Thank you so much, all the stalwarts, experts, especially Dr. Swapnil, Dr. Vardhaman, for making this webinar a very great success. Thank you so much.
Thank you so much, sir. Over to Aditi, please.
Yes, it was indeed a extremely summarized, comprehensive review of all the simple procedures. I'm sure it will be helpful for all, and I think it will be very helpful, especially for people who are from periphery, who may not have a very easy access to all the subspecialists who are there around more easily in the metro cities or like bigger cities. So yeah, first of all, I would like to thank all the speakers. All the talks were very nice with videos. They made it like real, like a live demo of the things. Special thanks to Dr. Swapnil Bhalekar, who actually organized everything and made sure that all the good speakers are delivering their pearls of wisdom. Thank you to the technical team and Entod, and thank you to our panelists. Special thanks to Dr. Somashila, who was there for the webinar to share her pearls of wisdom also. And yes, thank you once again from Team MOS.
Thank you, Dr. Aditi.
Okay.
Thank you.
Thank you. Thank you, everybody.
Everyone.
Yes.
And
thank
good
you.
night also.
Thank
Good
you,
night.
everyone.
Yeah.
Good night.
Bye.
Good night.
Thank you. Good night.
Thank you. Good night.
Thank you.